So this is a patient, 82-year-old, has progressive symptoms, also has SLE, antiphospholipid syndrome, pulmonary embolism, and many other comorbid conditions as shown there. And BMI is 18. Patient has been on apixaban and other medications for primary illness, and severe AS with the gradient of 2730. When there is also severe mitral annular calcification with moderate MR and little gradient only with a normal right heart pressure. So we can show actually those echo live by Dr. Lucy Safi is there, and they can show the live echo, please. Yes.
So thank you, Dr. Sharma. This is our parasternal long axis view. You can see mild left ventricular hypertrophy. You see that mitral annular calcification that he was talking about, and a heavily calcified aortic valve. Focusing on regurgitation, you can see the moderate regurgitation on the mitral side, not much on the aortic side. And then in short axis, you have your tricuspid aortic valve with restricted open and not much aortic insufficiency. Apical views show normal left ventricular and right ventricular systolic function, moderate mitral regurgitation, and our aortic valve is sclerotic. Our LVOT diameter is 2.2, and our stroke volume is 55, giving us a low stroke volume index. Our mean gradient is 28. Our dimensionless index is 0.25, all consistent with severe aortic stenosis.
Okay. All right. Let's go now. Our continuation on. Okay, this is CT tower, basically
Yes.
small annulus, as you can see here.
Yeah, so it's a small annulus. You can see there, the mean diameter is only around 21, area is 422. That would be within the SMART trial criteria. And you can see that there's a little bit of LVOT calcium as well. Sinuses are big. Next slide. And then you can see pretty high coronary takeoffs, no issues there. A little bit of posterior and ascending aortic calcification you see on the CT on the right side. You can see that here, as well the arch as well. We'll show you actually, we did an angiogram. There's a loop on the subclavian actually, so we're not going to do protection.
Okay, and
that's
looks
good. Looks good, but there's a big band, so on the left side, so we have to do some manipulation for the pigtail.
So this is a case which will fit into clearly the SMART trial, or the annulus less than 470 or 20 or 23 sapien, or 26, 29.
It's 29 actually.
Yeah, and 29 evolute. So this basically we decided that will be a 29 evolute FX under conscious sedation, and cath was done, which is normal, non-obstructive CAD. Okay.
Can you show us?
Let's
the
go in now.
sinuses again?
Yeah.
The sinuses of that valve.
Yeah.
Can you show us that CT scan? Because the sinuses.
Yeah, the sinuses are pretty wide, Kendra. It's like in the 30.
Show the fluoro by slides again, please.
That's why
I can show it. Yeah.
Yeah. This is the sinus is here. Yeah.
Yeah, the
Zero then.
the sinuses are a little borderline for the 29, but the other aspect here is there's that spicule of left ventricular outflow tract calcification.
Yeah.
And Kendra was part of the SMART trial clinical committee that evaluated patients who were borderline. And this was actually one of the main exclusions from the trial that some investigators felt uncomfortable with balloon expandable valves if there was more than a little calcification in the outflow tract. This one is sort of right on the fringe. I think most of us would be comfortable treating this either way, but it's on the fringe. What do you think, Kendra? Would we have excluded this from SMART based on that?
I think that the patient wouldn't get a 29 based on that.
Wouldn't get one?
Would not get a 29 size valve,
Right,
because
right.
per IFU, the sinus of Valsalva
Right.
dimensions are not large enough. So they would not have made it in the SMART trial for a 29 valve. 26 seems like it would be adequate. Howie, what do you think about a 26?
Well, I think it's right on the fringe. So you're going to get a little more paravalvular leak with the 26, and you're going to get a little bit more risk of sinus sequestration and pacemaker with a 29. So it's a close call. She is not what I would call a long-term life expectancy patient at 82 with multiple comorbidities, low platelets, all the other
Right.
things that you mentioned.
Yeah.
So I wouldn't be uncomfortable here with a slightly higher gradient than a 23 sapien either. So I think either one is fine. But I always worry when I'm in between sizes on one valve and optimal on the other valve, that choosing the one where you're in between poses dilemmas.
What's the
1 meter?
STJ? Is the STJ?
That's the right way to say it. Yeah.
STJ also small, or is it?
Yep.
STJ.
Tubular junction?
So it was the previous slide. 1 second. Let me go back to that.
There was no STJ measurements there, but it's around 20. I will show you the aortogram. Let's show you the aortogram. That's probably easiest to see.
Yeah, we'll show the aortogram, and let me just complete this, our presentation. As we said, that now we are going with a 29 millimeter. As Javi said, that of course, it's a little oversizing, but definitely 26 will leave more paravalvulally. Okay, now Anu, tell us where we are. Go back to Flora now. Yeah. Right.
We just crossed and we are with the pigtail in the LV.
Yeah, so let's show some floor angio. So here's the coplanar view, just for every the panelists and everyone. You can see high coronary takeoff. In the sinuses, I agree with you. This will be a 23 S3. The annular calcium availability in the long axis, so maybe less risk of annular injury. But I think from an absolute standpoint, I think you're going to potentially risk a PVF, especially with that calcium, if you use a 26. So this is the cuts overlap view. Here you go. See, very nicely done. And you can see this is the valve check. And here it is just to show you the arch. And you see that band on the subclavian to the nominate? So we're not going to be in favor of Centom. Maybe in Cleveland Clinic they can do it, but we're not brave enough.
I think
Valve,
the
please.
coronaries are unusually high, so I think whatever you do, this is a great lifetime. You can do another valve when she's 99 or 100.
Yeah.
Well, we still need to wait for 10-year data for TAVR, so at least for the trial, from the randomized trial.
No need to pre-dilate, right?
Yeah, so I think we'll go direct with this. What do the panels think based on the CT distribution and things?
Good direct. Yeah, I don't see anyone here who is for pre-deal, unlike the last time. So we're good to go.
Okay, good. Okay, let's.
Agree.
So what we do is the same thing. Careful your leg. Yeah. So we go into LAO view to look at our head marker. So we'll go there.
Can you explain a little bit more, because they asked the question last time about.
Yeah. So we'll go there. Let's go slow on the with FX. But those are flush point at 3 o'clock now. We established that. That's the way to do that. Okay, so we'll put it into the descending aorta. So what you're looking for here, a little bit more, is that the head should be in the outer curve or center back, and this is not a true LAO view. You would go more LAO, but I think it's going to be harder. Yeah. And so you can see what I'm doing is I'm rotating it from 3 o'clock to around 12 o'clock, and I'm going back to 12 just to see. You can only do it in the descending aorta. You can't do it in, So now I think it forcing that.
So let's go now. Okay, you read the flow.
Yeah, flow. Okay, so now we.
Okay. And
Good. So you can see that, the dots and the head marker. Okay, so let's look at it across the arch and see how it looks. So with the FX system single spine, you don't really have the issue of rotating. Like sometimes with the Pro Plus, we had issue of the head marker going from the outer to the inner, and now we're crossing the valve. So now we're going to go into cuts overlap view. It's a very small dynamic ventricle you see here. So our anesthesia colleagues have already actually helped us out by giving fluid, volume to expand.
pigtail, you need wire again?
Yeah. So it's very difficult with the pigtail because of the, pigtail, we could go to non. Yeah, fix the non if you can. We have time. Pressure is stable. So let's just take our time to do that.
Very tortuous aorta need a wire for all.
Yeah, you saw that earlier, the access is the band, and we need, maybe one of our panelists can invent a pigtail that we're stiff enough to withstand these tortuous anatomy. There was a band in the proximal common iliac, and that usually makes it harder for these kind of pigtails. We're doing up and over for our
Dr. Kapadia said
access.
the unilateral femoral access. You put a small femoral below.
Yes, they have done that
might
as well.
be good for this one.
That's right. Good. A little bit more. No, that's the ventricle.
Yeah, that's good.
Yeah.
That's good.
A little bit more. Yeah, that's it. Is it?
in the LV.
I think the non is on that side. Let's see. Blood pressure is okay, Benji? Okay, good. So you can see the head is a little bit off there because we did rotate, but we'll see how it looks. So we're not quite at the bottom yet. No, you're across the annulus. I think we might have to just look at the landmarks. There you go. There you go. Got it. We got it. Okay, good.
That goes to the,
Excellent.
Non-coronary.
follow
Okay.
the catheter of the valve. Just use more dye.
Yeah.
Yeah, that's good.
It's also pacify with more dye.
Okay. All right. Okay, 150. So, is it pushing? It's not capturing?
Yes.
Okay, now it is. Okay. Question, please. A little deeper. 100. Actually, not bad. Don't push. Push a little bit. Push a little bit.
Go forward.
Yeah,
Right?
yeah. Actually, it turned out better than I thought. Okay.
Hold
Good.
on.
Push more.
It's at 0. Hold on.
Push. I think it should be okay.
Yeah. 2 dots are below. And
Yeah, I think left is fine.
Yes.
What does the panel think? We would incline to release.
It's on the right side a little bit,
I
once
would-
you release.
Yeah. I would personally recommend recapturing and going down another millimeter or two. You're at 1 or 0, and I really don't think you need to do that, especially with a 29 in this patient. I think a 3 would be fine.
Can you show us in the cusp overlap view? Because we should really only be assessing the depth of the non in the cusp overlap view.
This is,
Bring the pigtail back.
And I may have missed it when you quickly rolled left.
Yeah, we
Show us
don't
that
usually
picture?
do that because there's so much parallax. I know Kendra is the PI for the Optimized Pro, but we kind of simplify this to make that really unnecessary. No.
Because I would agree with how you
But we
looked
can do
about
that.
1 and when you were in the LAO.
Initially, it was a lot deeper, I thought, and then during the deployment,
Yeah,
they kind of
it
pulled,
came
and
up, I
then it
think,
just at
afterwards.
once.
Maybe that's the dynamic nature.
So it came back quite a bit with the pulling.
Yeah, we are trying to advance the pigtail again because it's being curled up.
It's wrapped around.
Now let him see the top of
What's the pressure now, Benji? Okay, we need to put the mean. We can't be doing that.
Mean is 40.
Yeah, we can't deploy. We have to deploy this. Okay, we have to deploy, guys. We can't be doing
Well,
this.
Now, can you send what's happening with the pigtail?
I think if you're not sure where you
Can we
are,
get
you
a-
should probably recapture.
Huh?
it's very tortuous. We have to advance the wire.
Just 1 second.
Recapture.
Support that, please, Benji. Support the pressure, please.
Now to just deploy it
Can
then?
we just release?
Yeah.
Right?
Well, we have to check. We have to check again now because
No,
we.
it's taking another turn.
Advance the wire.
Why don't you
Wire is
recapture?
there.
Supracore.
Why supracore? Let's see on the
No,
top.
pigtail has. Okay.
Okay, good. Okay, well, we have some answers there at least. You can see where the depth is.
What's your thing?
Cannot advance this. Yes,
Okay,
release
leave
wire.
it, leave it.
Yeah, okay.
Release the valve.
Okay,
No need to rush.
push forward. Okay, you see where it is, right?
We need a,
There. That's our pigtail right now. Okay.
Yeah.
Everyone agree?
Yes.
yeah.
Okay. Okay. 150. Okay, Benji, we're releasing. Look at the respiratory aeration. Okay, moving slow. Y back up. Push forward.
Yeah.
Where's the Good, good. Not out yet. Not out yet. Good, good. Okay. All right. Okay. 120. Watch. Watch
Watch
out.
out. Still on.
Yeah. Well, it's not on. It's just that it's
Hey, that's good.
It just is the outer curve. It's not off. Yeah, 120. Good. Okay. So you can see actually the valve went a little bit deeper to our advantage. Okay, let's get a.
Okay, let me come.
Yeah, 100.
We need a new picture.
Yeah.
Okay, guys.
Back
This was
up.
a new pigtail with a regular wire.
Okay.
But it's a regular 35 wire.
Back up now, please. So we call it the cyanide push technique because we feel that if your left is okay, push forward, and we have not had a valve embolization because of the high on the non. So, but you're absolutely right in the panel that if you're really uncomfortable with that, definitely recapture. And it looked like it rolled up a little bit after annular contact, but everything so far So good. Should we look at echo in the meantime, or would you like?
So he does not have something to hear. That's the problem.
Good.
He's not hearing.
Yeah, we don't see pressure from here.
Yeah, we don't see pressure, it says.
No, we just, I know.
Yeah, we are fixing that right now for you.
Very pressure.
Yeah, we can connect to the sheet.
Benji, pressure.
Yeah, walk this out.
Yeah, give me, coming. Wait. Let's.
We don't plan to post, so walk it out.
Well, there's a good heart rate.
1 second.
1 second. Here, go for it, Dr. Sharon. Good, go. Should be good now.
No.
No? I already, okay. 1 second, advance this a little bit. It's probably stuck there, okay. Advance the wire.
Yes.
We see very nice QRSs on fluoroscopy, everything is good?
Okay, recapture a little bit, open the valve a little bit more, just so that uncapture. Yeah, turn towards yourself. Yeah, good. Yeah, good, stop. Stop, let's see. There we go. Good. It will just recap.
Okay, go fluoro.
I have wires, so just walk that system out, please.
He's bradycardic, huh?
Good.
Good.
Good, perfect.
Okay.
With the flush.
Beautiful.
Regular flush. Don't use this flush. Okay, pressure is all right. Okay, let's do the, yep.
Yes.
Thanks.
Yeah, let's do the aortograph.
Okay, good. So let's do the aortogram there. Very nice.
Okay, ready?
Yeah,
Go for I1.
yeah, go. That's good. But
Oh,
only
very
is
good.
why the patient become very bradycardic.
Yeah, I mean, it's the 29, right? So it's a little bit oversized, but that's
oversized.
okay.
But look at this, it's not above, it's actually a little below.
Yeah. No, it's fine. It's like
I'm in very good position.
Yeah, it's very good. Okay, echo.
Echo will tell us because I don't think we need to
No, we're not close.
post dilate. Yeah, put it.
Not necessarily.
No. No post-dilate, that's for sure.
Looks well expanded.
Already 18.
Anything.
So explain the head marker again.
Yeah.
You can see the echo now?
Yeah, we see the echo.
Yes.
It's pretty good.
So far, so good, yeah?
Yeah. You
Nope.
don't see a single RBC going to the ventricle.
Yep,
Looks good.
good sizing.
Yeah.
Good sizing and Lucy, what is the mean gradient you're getting?
I'll check right now.
But no PVL at all.
No PVL.
Yeah.
Yep.
As predicted, no PVL, and we just want to make sure the gradient is not an issue. And you saw that there's on aortogram came very good. Yeah. Looks like gradient 3, 5,
Yep. Mean gradient is 4.
4. Okay.
Beautiful.
Beautiful.
Okay, good job.